Happy? Okay, fun? No? Not the best song you've heard? All right. So we'll do a bit of repetition, and I'm going to show you a couple of pathology cases. But please ask questions, and I'm not gonna make you come up to the stage if you don't want to, but we'll see. All right. Can I get my slides on the screen? Yeah. All right. So a friend of mine, he's an anesthesiologist, and he works in a big hospital in Stockholm. He went up to a ward to get a central catheter in because it was a septic patient. They didn't have any vascular access, but he thought the veins on her neck looked so distended. And while they were getting all the stuff, since he of course brought his ultrasound machine, he took a look at the heart, and this is what he saw. So what window is this? Do you recognize the Mercedes sign? All right. So we call this view parasternal short axis on the valvular plane, right? So we're cutting the heart just like a tomato or a cucumber, something like that. But something's looking abnormally big here, right? And what valve should this be? On the left of the aortic valve in this view. Tricuspid, yeah. So this is going to be the right atrium, right, what's it called? Right ventricle, and somewhere here is the pulmonary artery, and here's the aortic valve. But what's this? Yes. Thrombus just waiting to go out in the pulmonary arteries. And some of them has already been sent away. Okay? So I guess she didn't have UROSEPSIS, right? She had something else. Just to show you. So what do you think you do with this, and if you find something like this? At least you know what treatment she should have if she crashes, right? They didn't give her lithics, just heparin infusion and stuff like that, nothing else. And it worked out fine. In some cases, you can actually go in with catheters and remove it or give local thrombolytics and stuff like that. But in this case, they didn't need to do it. Okay, the first gray picture there is something that we're all going to see in the beginning when we do cardiac ultrasound. But hopefully, with a couple of training, at least 100 times of training, you will definitely be able to get nice images like this, okay? So don't give up when it comes to cardiac ultrasound. This is usually how it works in Sweden when we have ultrasound courses. I don't know if you... and that's Mike from Ultrasound Podcast. He nowadays he walks around in Salt Lake City like that as well. Right, but we have a problem when we're doing cardiac ultrasound. As you notice, who doesn't hate the ribs when we're trying to do cardiac ultrasound? I, at least. The ribs are always in the way. They're on the wrong place. And sometimes it's even hurting the patient, stuff like that. So that's one of the problems. That's why cardiac ultrasound is hard, because we have to go in between the ribs. We have to find the perfectly good rib space and go in between the rib space. That's why we also have the subxiphoid view, right? That's the subxiphoid view. But remember how the ribs are, how they look. So usually, a way to get a really nice view, especially an apical view, is to stand on the rib below and then just look up like this. Just tilt the probe and look up, because the heart is so close to the chest wall, right? I think you notice that now when we're scanning. It's hard to get the perfect angulation and open up all the the rooms of the heart. So think about that. Slide down, stand on one rib, look underneath, and work with. It doesn't have to be perfect if the patient's completely on the left side. Sometimes it's better if they're like this, or might even be on the back. Yeah, you've already seen this, but this is what we're struggling with, right? But so don't give up. And I think I'm just going to tell you, I have 3 favorite applications for ultrasound, and it's vascular access, lung, and cardiac. Of course, I'm biased since I work with internal medicine, but at least in my country and most of the European countries, gunshot wounds, stab wounds, or super big car crashes isn't as common as heart failure, COPD, sepsis, stuff like that. So I'm sorry, but you have to focus on the boring stuff now. So, okay, it's good. It's much more rewarding. All right. So let's repeat this again. Have you seen this thing before? Is there anyone that has any questions about what's what and stuff like that? So it's a good thing, and I'll give it to you guys so you can send it out if you don't have it. Otherwise, just Google Rush protocol. So this is from one of the Rush protocols, which sort of summarizes everything really nicely. So, but don't ever just look at the heart or whatever, or something like that. Try to do the whole exam, okay? Here's another protocol from Dr. Lichtenstein. I think you're going to hear about him tomorrow during the pulmonology talk. He is like the godfather of lung ultrasound. He's also came up with this is mainly focused on lung ultrasound findings. But as I said, there's so many protocols. Just pick and choose whatever you like, but have something that you do and tick off. So have a look at the heart, have a look at the IVC. Is there any fluid in the wrong places? Is pneumothorax, aorta, and maybe DVT. Sorry about the quality of this, but this is it's called the not Sturm. I had one glass of Sturm yesterday. Never again, please. No offense. The Storm manual. It's free download on iBooks. You don't have to buy it. It's an ultrasound book that's written by Australian guys, a friend of mine, Justin Bowra. But it has a couple of good. These are the 7 golden rules by Dr. Bowra, and I already told you the last rule, right? But as we said, me and Stefan said as well, when in doubt, be a doctor. If the clinical picture doesn't adhere, correlate with the ultrasound, do pretend as if you didn't do the ultrasound, or have someone else to do the ultrasound and confirm it, right? And repeat scans, always. If the patient's sick enough to do an ultrasound on, go back to them when you've given them treatment. Go back and do it, just as we've been talking about fast scan as well. You need to go back. That's also one of the best thing with ultrasound. You can do it as many times as you want to, right? And this also, right? Focus on what you know and what you can actually find. Sometimes we find something very strange and we can save a clip or whatever, or actually see it for the first time and come up with it. But first of all, focus on what you know that you can actually see and find. Okay, here's a case. A patient comes in dyspnoic, tachycardic, doesn't say much, then he's short of breath. What's the name of this view, the window? Good, good. Is there anything wrong with it? Does anything look strange for you? I agree. The right ventricle looks a bit big, right? Especially as Stefan said, if you compare it, the diameter here, here, and here. But you can also see that the left ventricle is almost like touching, like kissing walls, as if you've heard the expression. So maybe that something like that's going on, right? So let's have a look at the next view. Then we just turn the probe, right? 90 degrees clockwise. In the same footprint, we don't move the probe, we have the same footprint, just turn it 90 degrees clockwise. And what do you see? What do we call this sign? D-shaped sign. And that's caused of that the pressure in the right ventricle is higher in diastole than in the left ventricle, right? So it can't sort of relax into the right ventricle as it usually does. Okay? And then here you can see the same thing. Here's actually another sign of that gives as a suspicion of a PE. That's called, does anyone know what the sign is? McConnell sign. Hyperdynamic apex in the right ventricle. It's mainly caused because the left ventricle is empty and it's working hard, right? So it sort of draws the apex, but the rest of it is not contracting as well, right? You see that? McConnell sign. And once again, if we are lucky, the patient is unlucky, or how you should see it. Here's another thrombus again. Doesn't look nice, right? So let's try to stay away from that. So these are the main things that we can find and we should focus on when we have a look at the heart. Also pleural effusion, which affects the cardiac function, especially if it's evolved quickly, right? So you can actually increase the left ventricular function if you drain the pleural effusion. These are all short axis, peristernal short axis views, right? And I think this should be a subcostal window. All right, let's see what happens here. If it's playing. Okay, someone asked me, where's my computer? Someone asked me about how does it look if you have a papillary muscle rupture? And that's what we have up here. Do you see that flickering thing up there? That's a papillary muscle rupture. And here is a lady whose dog died suddenly by a car crash. Did you see that it wasn't moving at all up here, but moving down here? That's what some people call the broken heart syndrome, or takotsubo, or apical ballooning, stuff like that. Caused by severe stress, usually psychological stress, sometimes physical stress. It has a good prognosis, but you can actually go into a cardiogenic shock just by that. And this guy hasn't been taking his hypertension medication, right? Severe hypertrophy, which might result in a left ventricular outflow problem, but also they're super sensitive to hypovolemia, tachycardia, okay? So if this guy comes in with some kind of shock, what he needs is we need to reduce the heart rate and often fill up the heart, right? I was joking with some of you that you might end up in prison if you hold a probe like this, at least in Sweden. But what you need to do when you do cardiac scanning, hold the probe as close to the surface, to the plastic surface of the probe. Always rest your hand, rest the back of your palm, or have a couple of fingers or something in the patient. That's the way to actually be able to relax your hand and make small adjustments. I think you noticed if you're holding it like this, you're going to be sliding all over and losing the image all the time, right? And your shoulder's going to hurt like hell the next day. Same thing again here. Okay. I think you know all these views, and we've done that. And preferably, if we're lucky, we get views like this. But still, you can make so many diagnoses of just getting this view and just getting this view. But as we said, if you see pathology, you want to see it from two views. Okay? All right. So this guy, he's from Newcastle. I think it shows, right? He's English. But Bob is an excellent sonographer, a very good friend. But he came up with this. After ABC, don't forget the D, E, F, G. Okay. Have a look at the dimensions, the effort, which means how does the left and right ventricle move? Is there too little fluid in the heart? Is it fluid around the heart? And then maybe have a look at the gradients. Just start by looking how the valves seem to be opening. And the next step might be using color Doppler just to see if there's any leakages. Just a short thing about pericardial effusion. It should be around the heart. If they haven't had cardiac surgery or something like that, it might be localized. As you see here now, the image flipped, and here's pericardial effusion, right? It's also, as we said, it's more of a rate of the accumulation than the size. There's stories about more than 2 liters of pericardial effusion that's been drained and stuff like that. But that's been evolving for a long time, right? And whenever you're measuring the amount of pericardial effusion, measure it in diastole, right? So what's going on here? What kind of view is it? What's the window's name? Sorry? Yes, peristernal long axis. We see the mitral valve, we see the aortic valve up there. But there's a couple of black things here, right? This is pleural effusion, right? And this is pericardial effusion. Pericardial effusion is going to go underneath and sometimes sort of dislodge. What's this? Descending aorta, yeah. And of course, if you're not super strangely built, pleural effusion is going to respect the midline, right? Because this is left-sided pleural effusion, right? Okay? So that's a way to differ between those things. All right. So hemodynamic compromise with known pericardial effusion. Just as you said, a patient should be in shock or have low blood pressure with the pericardial effusion. Then they have tamponade, right? They also are going to show you an enlarged IVC. Quickly about left ventricular function. These are roughly the numbers that we use: normal, moderately reduced, and severely reduced, less than 30%. And as we were talking about this morning, have a look at the thickening of the wall, and an easy way to see is how does the mitral valve open, right? thickens nicely, and the mitral valve is flapping up, touching the septal wall. Bad, very bad, right? And you see the difference. Dilatation, no thickening at all, and just a small flickering of the mitral valve. That's the EPSS, and then you can actually, with M mode, measure it if you think you have time. This was a guy that came into my emergency department at 3 or 4 in the morning. It should, 4:40. Do you imagine how that's like the prime time, of course, in the morning. You really want a super sick patient then. Anyway, he had so much pain on his lower lungs or whatever sides. So we thought about, and he couldn't even sit still. He couldn't breathe properly and stuff like that. So we scanned him, and what did we find? We found this. So this is the liver, the diaphragm, and something black up here. This is the spleen, something black up here, the diaphragm. Let's see if we can't play him. Oh yeah. He didn't have any fever, but when the CRP came back, it was elevated. So what do you think he has? Bilateral pneumonia with some pleural effusion, right? So what we actually could do is to aspirate some pleural effusion to get a culture, and also see what was going on. He was from an African country and had been there, so then you could of course suspect a lot of dangerous diseases. But this was just a normal pneumococcal disease, I think. You can also take antigen on that pleural effusion just to get see if there's any pneumococci or anything like that. Okay, are you convinced that it's kind of useful? You already were. But once again, this is how it's going to look from the beginning, and it especially did for me. It's really annoying, but keep on working, all right? So now I'm just going to give a couple of tips on how to get those cardiac windows, all right? Where's my body? Just like a typical Swedish patient comes in with his beer. It's usually beer and Facebook on your phone, and you're complaining about that you have the worst chest pain ever in your life, right?
I saw that you brought a beer with you at the beginning of the lecture, so I thought I would get one too.
Yeah, it was just because I was afraid Simon would take mine. So.
Yeah. Usually there's like spots where you can.
Yeah, you can fit it here. Perfect.
Yeah, no, we can one there.
All right. Okay, so we start with a subcostal view now. So let's pretend we're doing a rush protocol, but we start with the heart, of course. And for the subcostal view, remember to hold the probe from above, right? And what I usually say is to try to imagine that you're scooping up the heart. Don't start high, start a bit lower down, and always in the midline. Never cross the midline. It's really, really uncommon that you have to go towards the left side of the patient. Usually, you actually have to go a bit to the right side of the patient because they're either had eaten or drinking a lot of beer, or someone has been ventilating. Yeah, both. It might even be both be a Big Mac and a lot of gusser in it, so you never know. Okay, so I start low, I find the liver, right? And then just scoop up the heart, all right? And then make small adjustments. But I hold my hands very steady and make small adjustments. Sometimes you can ask the patient to take a deep breath, and it might enhance the picture because then the diaphragm pushes down and the heart gets closer. Okay, so exhale. And I usually don't care about the apex too much in this. I only want to see that it squeezes, that there's no pericardial effusion, that the right ventricle is sort of like pie-shaped and nice like this, all right? Then I go for the IVC, and same thing, just in the same footprint, just turn 90 degrees. And I try to do it a bit quick, right? Because otherwise it's easy to slide around and miss it. So, and the other way to do it is just you've been doing something else and then you just want to have a look at the IVC. I put the probe in the center in the midline. First we see the aorta, of course, and then I just slide it towards the left. Just slide, and then there we have it. Remember that you should see the right atrium when you're looking for the IVC. Otherwise, you might be fooled. It might be a liver vein or even a gallbladder or the aorta or something like that. So remember, try to view the right atrium when you have a look at the IVC. All right? And if you're using the sniff test, be careful because some of the patients are going to sniff so much that you're actually going to lose the IVC out of the window, right? So you might be fooled that it's... Do you understand what I mean? Okay? Good. All right. And this is a bit more than we talk about, but I'm just going to show you it because it's kind of cool. If we do a reverse IVC, we're not looking for the IVC, but I'm turning the probe the other way, and you see what we get then? Okay, so it's like a peristernal short axis, but you can actually get it from here. In some patients, it's impossible to get anything from the chest wall, but here we can actually get a nice peristernal short axis, or subcostal short axis, of course, and get lots of more information as well, right? So the movement I did was for the IVC, I turn it like this, and for the short axis, I turn it the other way and look a bit more towards the apex, okay? So we can practice that in the afternoon if we have time. For the peristernal long axis, try to be as close to the sternum as possible, okay? And press a bit hard because you actually are available. It is possible to sort of expand the intercostal room just a little bit more. So once we've found something that's pumping nicely, then same thing, we make small adjustments with the hand and see what happens if we turn it too much, but I'm only doing one movement at a time, no tilting and turning at the same time. Huh? But this is also just a matter of practice, and I must say this model is, I mean, if everything else fails, you can start a career as an ultrasound model, definitely. I don't know the pay, actually. It might be okay. So now, what I do, exactly the same footprint, just turn the probe around, okay? And we get a nice view of the papillary muscles. And same thing here. Sometimes you have to adjust it, but sometimes you can just, exactly the same footprint, just tilt the probe up and down, okay? And here comes the famous Mercedes sign. Has Austria ever built any cars? No? Porsches? Yeah, you know how well the Swedish car's going. I had a Saab. It died. All right. Now we go, just one last thing. So if we have a nice peristernal short axis like this, one of the tricks you can do is actually to slide in that intercostal space towards the apex, okay? So you just slide, 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 you have it in the view, and then just tilt it, okay? And then at least you know you're around the right point, site. Did you see what I'm doing? So you just follow, you see the heart all the time, and just slide down there. And we're talking about that, and now I think you feel how pleasant the Swedish rib massage is, right? So I'm standing on the rib, really looking above it, because then I can cut the heart in the right angle, okay? And it's super annoying when the patient's breathing, but sometimes they need it, so you shouldn't try to adjust for that, just hold the probe still. Wait a couple of breathing cycles. If we want to see the aorta, sometimes we can just turn it a bit and tilt it, but now he's on his back, right? There comes the aorta in the middle of the picture. I think you should actually practice on the patients being supine like this. If it doesn't work out at all, then make them turn. But most of the sick patients they're not going to help you, and they're not going to. They won't turn to the left side for you. So practice on this, all right? So the idea with Rush, right, is that we have okay? Put on the timer now. Does anyone have a timer? You? Okay. So let's see how quickly we can do this. But we need 2 judges that say that the image is okay. You can just sit there, and then you say the image okay, and then I continue, all right? Do you understand? Okay? And if I win, we'll see what happens. I get...
No, you don't get my beer.
Crap. The gelling doesn't count, right? Don't start to... No. No, he's sick. I mean, I haven't started yet, so someone's gelling him up all over the place like this. This is how we usually do in the... All right. Okay. Okay, no pericardial effusion, the heart is moving, and right ventricle is okay? Yeah? But we just want to confirm that from the peristernal long axis. Looks okay, no pericardial, blah, 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 and everything's opening nicely. Good. Then, high map, right? IVC. Let's see, does he have any IVC? Is he breathing? Okay. It doesn't look too distended, it's moving a bit, so okay, I'm happy with that. Then, Morrison's pouch. I'm using the cardiac thing, so we're going to do it like this. Okay, it looks nicely here. No signs of peritoneal fluid, and there's no pleural effusion either. I'm happy with this. Are you happy with it? Okay, good. Next. And then this is where you tell me you had a splenectomy, right? So I don't see any free fluid around the spleen. It looks like you have a huge amount of pleural effusion on the left side, but I don't care about that. And it looks nicely here. Are you okay? Okay, small bladder, big prostate. Don't laugh. Okay. I don't see any free fluid in your pelvis. And now take a couple of deep breaths for me. Okay, so I see lung sliding here. Does everyone see it? No, you're not happy with it? Oh, beautiful lung sliding here, no? You don't think so? They're hard, huh? And here's the aorta. And what's on top of the aorta? The round structure? Yeah, an artery, good. Okay, so I'm following the aorta down. Here's the bifurcation, does everyone see it? Here's the beer, I'm passing it. Okay, so it doesn't seem to have any aortic aneurysm either. Okay, do you want it, shall we check for DVT as well? Since he has his speedo on him. There. Venus. Okay. Fully compressible. No DVT there. Start very high up, compress, stepping down. No DVT. Not the. Do you see the vessel up there? Do you believe me? It's a popliteal vein. Up. Let's increase the gain a bit. I'm starting to get sweaty here. Okay. You see it? Down there. No DVT. All right. Just to make, since you were complaining so much about the lung sliding, he doesn't have any pneumothorax, right? Okay. Here is actually the mammary artery. You know the black one that runs underneath there? That's the mammary artery. All right. 4 minutes 25. Sorry? 4 minutes 25. Oh, the patient died after 1 minute. Too much talking, eh? All right. Any comments? You happy with this? So now you know Russia.
Well, I think patient is alive. And I think that was quite a demonstration here. Thanks a lot. I think that summed it up really, really well, what we're doing with Rush. And this
is how they should look afterwards.
Yeah, just so you can see, so you can all see. Well, yeah, the back is fine actually, but the front is pretty much fully covered. So what we're doing next is quick. Well, thank you first. Thank you again. Organizational stuff for you guys. We're next doing a group photo out there. I'll just quickly get dressed. So please, everybody get into the courtyard. It will be 2 minutes for a group photo, and then we'll continue with the hands-on sessions. Well, thanks again, Chris. That was quite a performance.